Good afternoon. We're live. It's Thursday, August 13th, 2020, and this is the bi-weekly healthcare provider webinar presented by the New York State Department of Health here in Albany. I'm Dr. Elizabeth Dufour, Medical Director in the Division of Epidemiology at the State Department of Health. Joining us this week to update healthcare workers with our latest guidance on COVID-19 are Dr. Marcus Friedrich and Dr. Louis Nitkoff. Due to the large amount of interest in our bi-weekly COVID-19 guidance updates, we are offering different ways to listen to this webinar live and on demand. The audio and slide deck can be seen on YouTube Live. Point your web browser to coronavirus.health.ny.gov/weekly-healthcare-provider-update. The YouTube Live player is on our healthcare provider's webpage. It's mobile friendly, so you can watch right on your smartphone or tablet. An on-demand version of the webinar is available via YouTube. Go to coronavirus.health.ny.gov, click on the providers link at the top of the page, then click on the weekly healthcare provider update. It's available immediately after the live webinar concludes. Now let's quickly go over the agenda. As usual, some situational awareness updates for global, national, and New York State case pictures, testing updates, travel advisory updates, reopening and community mitigation, strategy updates, travel advisory related to healthcare settings, telehealth, preparations for the fall, healthcare provider wellness and resources, followed by a question and answer session. Here on this slide too, here is the link for where the recordings and the webinar is available immediately thereafter on the webpage. In addition to YouTube, an on-demand version of our weekly sessions for healthcare providers is now available as a podcast. Search NYSDOH. So the overall global summary, as many are aware, we have continued to see steady increases in the global numbers with now over 20 million confirmed cases and over 730,000 deaths globally. And we see here, if you look at the last line for the Americas, really more than half of the global picture coming from the Americas, with the two largest contributors there being the U.S. and Brazil, with over 10.7 or almost 10.8 million confirmed cases in the Americas and over 390,000 deaths. Here we see the PAHO region, the Pan American Health Organization region of the WHO is in the yellow color, and we see that just continues to increase and consists of a large, more than half majority of the cases globally. Here we see the national picture. As many are aware, nationally, we are now seeing over 5 million total cases, over 160,000 total deaths. And you see here that as of August 12th, 1,562 cases per 100,000 people nationally. Unfortunately, some recent metrics have revealed in total the U.S. is averaging approximately 1,000 deaths per day. And this map shows us cases over the last 7 days, again highlighting the challenges seen primarily in the West, Midwest, and South, with the Northeast maintaining much lower rates as seen here. The epidemic curve for the national picture as of August 12th is here. Again, we see that second peak. We are starting to see a bit of a decrease. Hopefully this continues. Some of this could be a reporting lag. However, we are seeing this a little more prominently this week as opposed to presentation 2 weeks ago on the last webinar. And now for the New York State picture. Thankfully, we've maintained low rates throughout New York State. We see here the map and on the left the total numbers. So we've had over 6,700 instances of individuals being tested in New York State since the start of the outbreak. And on the 11th alone, over 87,000 individuals being tested. Our total positive, over 420,000 individuals, with 700 on that one day. Actually, we have some new information not available on the tracker yet, that yesterday 87,900 individuals were tested. That's a new record high, and 737 were positive for a 0.84% positivity rate. And we've continued to see on a daily basis approximately 500 to 700 positives on a daily basis. We see here the blue area in this epidemic curve for New York State, revealing those tested. The yellow, orangey color is those who are positive. And thankfully, even after phases of reopening, we have continued to see low numbers of positivity. Unfortunately, still over 25,000 fatalities noted statewide. And as far as our healthcare utilization, we continue to see low rates. Again, reviewing this so everyone is aware of what's what's going on in our picture here in our communities and in our hospitals, but thankfully low rates of COVID-associated hospitalization, ICU, and intubations. So currently we are at 555 COVID hospitalizations statewide, decreased by 3. Newly hospitalized, 86. Current ICU, 124, which is relatively flat, increased by 1. Current intubations, 56, so that's a decrease by 6, and a new low since mid-March for a number of individuals currently intubated due to COVID. And cumulative discharges from COVID hospitalizations, almost 74,000. Unfortunately, 10 deaths again yesterday, but thankfully the fatalities have been consistently in the single digits to 10 to 11 or 12 daily. So for some very brief updates on testing, the primary concerns that we are seeing at this time are, as many are aware, related to prolonged turnaround time for results. We at the state are working aggressively on assisting labs and improving this picture. In the interim, we recommend that individuals or providers call ahead to find what the turnaround times are at their lab and consider seeking out smaller local labs able to do COVID testing with shorter turnaround times, particularly the larger national reference labs, commercial labs that many of these, say, urgent care centers might use, or pharmacies are particularly challenged given the national picture and the need from other states, and are seeing quite long turnaround times in the 6 to 10 day time range. Again, importance of filling out full information on the lab test requisition form for any, wherever the test is going, just to reemphasize that importance so that contact tracing can begin immediately, because our testing and tracing strategy requires getting in touch with folks as quickly as possible and identifying their contacts and ensuring they are quarantined. And we've had a lot of question about rapid antigen tests. They're more and more available. While they do have some decreased sensitivity compared to molecular tests, similar to flu antigen tests, they certainly offer advantages in their accessibility and rapidity. But a reminder that these test results also need to be reported to public health as well. If anyone is unsure how to report these tests, since they don't follow the same, it's not as easy to follow the same electronic lab reporting processes as with some of the larger clinical labs. If individuals are using an antigen test in your healthcare setting, you can reach out to our healthcare provider BML. It's
COVID provider info@health.ny.gov.
And we can get back to you with the appropriate information on how to ensure that your antigen tests are also reported. The importance being, as seen here, last webinar we showed this slide on the contact tracing initiative. And the aim of the contact tracing initiative, as everyone is aware, is to, as quickly as possible, reach out to individuals who are positive to identify all of their close contacts and ensure that those individuals are quarantined, tested as appropriate, and limit the spread of disease in the community and maintain these low rates that we are at right now. However, we from clinical labs receive these results through electronic lab reporting with a rapid antigen test that's done point of care in a healthcare setting or even potentially a college setting. This is something that where these need to be sent to the local health department so that the contact tracing program can start, and that's where the arrow is indicated right there. To quickly review some community mitigation and reopening strategy updates. Again, the map showing here, all green. As everyone is aware, throughout the state, we are maintained at a phase 4 reopening level. Given the low rates, which includes the ability to initiate pre-K to grade 12 schools, higher education, low-risk outdoor activities, media production, professional sports with no fans, and outside of New York City, low-risk indoor arts and entertainment and malls if they have advanced HVAC approaches. However, New York City is still maintained without indoor activity, such as malls, restaurants, or cultural institutions. A new update here is that all 64 SUNY campuses have developed plans to resume on-campus activities and in-person learning for the fall 2020 semester, and the link is there for some of the details of the reopening plans and the safety measures. Again, to show the region dashboard, the early warning dashboard here. Again, this shows the same low positivity rates, but here you see the regional breakdown is available. And we see that there's a low rates ranging up to 1% in the Mid-Hudson region at the highest. Of course, the percentage can be affected by the denominator and the number of tests being done. And we know that there are, for instance, low-risk individuals such as college students being tested and others who may be lower risk being tested, and that could impact your percent positivity. So, of course, it's essential to also look at the actual just rate of new infections per 100,000 population. And here we see on a 7-day rolling average exactly that. And we see that it's maintained at quite a low rate of 3.27 per 100,000 is the most recent number. And this is a visual representation of the hospitalization and ICU data presented earlier. So how do we keep our rates low? As everyone is aware, continued safety measures with reopening and continued travel advisory approaches so that individuals traveling from states with significant community spread are quarantined for 14 days. The website, as mentioned previously, maintains a current list of states meeting the criteria for the required quarantine, which is based on a 7-day rolling average of positive tests in excess of 10% or number of positive cases exceeding 10 per 100,000 residents. Of note, the update here is that this week, Hawaii, South Dakota, and the Virgin Islands were added to the list, and taken off the list this week, Alaska, New Mexico, Ohio, and Rhode Island. And the link to the Traveler Health Form is available there. Other news that many are aware of since our last webinar is the pre-K through grade 12 reopening plans. This was decided the first week in August. So based on each region's infection rate, schools across New York State are permitted to open this fall with in-person instruction. However, each school district must have a testing and tracing plan. The schools don't have to test, but they need to have a plan to engage with their local health departments and other community-based organizations to enact a plan to approach testing and contact tracing for those pupils who will need it. And then each school district can decide on if an in-person versus a hybrid model works best for them while following the guidance, which is available at the link on this slide from the New York State Department of Health. School districts must post their remote learning plans on the webpage publicly, as well as plans for the testing and tracing with their community providers and local health peers. School districts must set dates for 3 to 5 discussion sessions with parents and the community members to be held all by the 21st of August, with at least one separate discussion with teachers. And again, the in-person versus partial reopening to be determined locally by each school district. Now for some brief COVID vaccine updates. This is a slide from the last webinar on a number of candidates in preclinical evaluation for COVID vaccine, clinical evaluation, and different levels of clinical trials. I've highlighted in blue here the studies ongoing in phase 1 and 2 trials, as we will speak about one of these today. Previously, we spoke about the currently enrolled in phase 3 trials, RNA candidate by Moderna and NIAID, the messenger RNA vaccine platform. And now we'll speak about another messenger RNA vaccine platform which just completed phase 1, phase 2. This phase 1, phase 2 clinical trial of a messenger RNA vaccine encoding the spike protein for SARS-CoV-2 was published in Nature this week. The vaccine candidate is by Pfizer and a German biopharmaceutical company, BioNTech. And the vaccine did show it produced a robust immune response and was tolerable in 45 healthy volunteers who were ages 18 to 55. They were given 2 doses separated by 21 days. And overall, this phase 1-2 trial supported further evaluation of this particular mRNA vaccine candidate into phase 3 trials. And it's through phase 3 trials only, of course, that we will have a further understanding of efficacy of this vaccine. Notable here, I would like to mention Dr. Mark Mulligan and his team at NYU are listed here. He is first author in this important publication. So we do have our peers at NYU involved in this important study. Before moving on from the topic of vaccines, I will mention many may have heard in the lay press reports of a vaccine being, quote, approved, unquote, and in use in Russia. Vladimir Putin announced on state TV that the vaccine was, quote, registered, unquote, and that his daughter had received it. We do not have any further information on the vaccine at this time, as it has yet to be published in the peer-reviewed literature. There are lay lay press reports suggesting it is an adenovirus vaccine, and that efficacy and safety phase 3 trials were not yet complete, but they have decided to engage in rollout prior to their completion. However, we have do not have any publications yet available for our scientific review, and I just wanted to cover that topic. For other vaccine updates, at one of our next webinars, we will have our Bureau of Immunizations Director speak further about flu vaccine for this fall season and other efforts that we all will need to engage in to address and emphasize the importance of flu vaccine and flu prevention in the midst of this COVID pandemic. Again, this slide is a reference slide for folks to have the link here if community members or patients are interested in engaging in a vaccine trial. There are several sites in New York State, and individuals can sign up here and be routed to the most appropriate trial in their vicinity. Along the lines of school reopening discussions, we have had many questions about pediatric COVID and the role of pediatric aged patients in the COVID outbreak here. And so we at the State Health Department have engaged in some of the national publications over the last week on this topic, published in the MMWR CDC publication, the Morbidity and Mortality Weekly Report. So to review the first one, we see here this link takes you to the article, the MMWR article on hospitalization rates and characteristics of children aged less than 18 years hospitalized with lab-confirmed COVID-19 in the COVID-NET program, with 14 states engaged in this evaluation from the time period of March 1st to July 25th. In New York State, our Emerging Infections Program participated in this COVID-NET publication, and this consists of 15 upstate New York counties where it is a lab-confirmed active surveillance for hospitalization with COVID in 15 upstate counties, population-based assessment in 8 and 7 counties surrounding the Capital District area and the Rochester area, respectively. In total, 576 children were identified who were hospitalized and reported to the COVID-NET surveillance system. And some of the key findings here: while the cumulative rate of COVID-19 associated hospitalization among children is relatively low, at 8 per 100,000 population of children in that age group, compared with adults, 165 per 100,000. Importantly, out of those children hospitalized, 1 in 3 hospitalized children had severe enough illness that they required ICU admission. Also notable were the significant race and ethnicity disparities as described in previous evaluations in adults and other evaluations such as in multisystem inflammatory syndrome. And in this evaluation, 46% of the children hospitalized with COVID were Hispanic, 30% were Black, and 13% white, with rates of hospitalization in Hispanic and Black children nearly 8 and 5 times, respectively, the rate among white children. Thankfully, case fatality rates in this evaluation remained low in children. Among 208 children in this evaluation with disposition available out of the 576, one child who had multiple underlying medical conditions died during hospitalization. In summary, children are at risk for severe COVID, and that's an important message for us to continue to get across in our communities to reinforce prevention efforts, particularly in congregate settings that serve children, such as child care centers and schools. And another update was provided on multisystem inflammatory syndrome in children throughout the U.S. from March to July 2020, again in MMWR. And again, the New York City Department of Health and Mental Hygiene participated, as well as the New York State Department of Health and our colleagues here, and contributing significantly to this publication by the CDC. The initial findings, key findings here, are similar to what has already been described during these webinars, that most cases of MIS-C have features of shock with cardiac involvement, GI symptoms, and significantly elevated markers of inflammation, and have positive laboratory test results for SARS-CoV-2. Also, again, reiterating previous publications that this seemed to occur approximately 2 to 4 weeks after the onset of COVID-19. Interestingly, we did find that distinguishing MIS-C from other severe infectious or inflammatory conditions is a challenge to clinicians caring for children and adolescents. And using the CDC definition, a total of 570 U.S. MIS-C patients were reported to the CDC during this time frame who met the CDC case definition. However, a total of 203, or 36%, seemed to have a clinical course really consistent with previously published MIS-C reports, characterized by the shock, cardiac dysfunction, abdominal pain, and markedly elevated inflammatory markers, and almost all had positive SARS-CoV test results, particularly positive serology. The remaining 64%, or 367 MIS-C patients, had manifestations that appeared to overlap with acute respiratory COVID infection, had a less severe clinical course, and/or had features of Kawasaki disease that may or may not have been related to COVID. So again, more to come on MIS-C, as it can be a challenge to parse out from other conditions here. And that's the update on that evaluation. Now we'll hear further from Dr. Marcus Friedrich, Chief Medical Officer, Office of Quality and Patient Safety here at the New York State Department of Health.
Hi, everybody, and thank you, Liz, for these great updates. I just want to point out a couple of things that I also mentioned last week. The travel advisory can be confusing, as you mentioned, Liz. There are, states added and taking off, and I just want to again emphasize there is a New York State website available. The link is on Liz's website, but I just want to mention it as well. coronavirus.health.ny.gov/COVID-19-travel-advisory. And there is the most updated list of states that are included in the travel advisory. And we got to be vigilant, because holiday season is clearly here, and there are high levels of community spread around the nation. And therefore, I just want to highlight a couple of important points that I also mentioned 2 weeks ago, that healthcare personnel are essential workers. They have, as the rest of the community, also to quarantine for 14 days, but that their employers, the healthcare entities, may allow that they are returning to work if they meet certain conditions. If they had a test and the test is negative within 24 hours of coming back, if they continue self-monitoring, temperature checks and symptom checks every day, and then self-quarantine when they're not at work, at least for 14 days. The other issue, as we see that the students are slowly coming back, they have to require to adhere to essential workers guidance upon return, and making sure that they adhere to the standards that their schools are putting forth when they come back to campus. And then, of course, our patients are, at least in my practice, are asking, what does a negative test mean when I come from another state? Can I come out of quarantine? And the answer is no. As you know, there is a lot of infection and transmission happening after the initial coming back, and therefore they have to adhere to these 14 days. And those are the updates. On the telehealth, there's also a very interesting new development. As you know, 10 days ago, the Trump administration made an announcement and signed an executive order to expand telehealth benefits permanently, which is amazing for Medicare beneficiaries beyond COVID-19 and beyond the public health emergency. CMS followed and is proposing changes to their current rule and seeking public comments that can be submitted to them by October 5th, and then the CMS will decide upon. This can be seen as a signal to other programs, but also the commercial payers here in the state, that these changes that are including telehealth may be here to stay. And so I feel this is a really strong signal that will, in the future, in our practice, will include telehealth and payment for telehealth. And then last but not least, couple words towards the preparedness. Nobody knows for sure if there will be a potential second wave, but we here at the DOH, but everywhere, are worried about the impact of the fall when people are starting to get more indoors, and the looming flu season that is upon us. And I think although nobody knows exactly how this will happen, we are pretty sure that this will come with a high likelihood, and that therefore the Department of Health, but also the state government, we're doing everything to be prepared for what might be happening. And the focus areas, as Liz mentioned, are clearly, the testing side. I think testing is one of the key pillars of the strategy going forward, identifying cases early, making sure that we then trace them and identify them, and making sure that we isolate them so they cannot go around and working or infecting other people. And DOH has oversight, but we are working very closely, of course, with our partners in the local health departments and making sure that this is being done and focused upon. Then the next area, of course, is the capacity of hospitals. What we experienced here during March and April, we want to make sure that we are, if things happen again, that we are prepared, and that includes also the reevaluation of alternative sites. And then, of course, PPE, masks, gowns, ventilators, making sure that we have stockpile in place that could be deployed quickly to areas where there are hotspots. And then also thinking about deploying HR or human resources to the areas that are in need when there is a need for, quickly doing certain actions to prevent further transmission, and also hotspots, such as we've seen these testing sites that were manned by DOH and state staff, and if there are certain hotspots, that we can quickly mobilize again our workforce to make sure that our residents here in the state are safe, and that we are also avoiding wide community spread. And I think that is the key going forward. And with that, I want to hand it back to Liz.
Thank you, Marcus. Now we will hear about some quick tips for clinician well-being in the era of COVID by Dr. Louis Nitkoff.
Thank you, Liz, and good afternoon, everyone. It's good to be back talking about clinician well-being. We're going to be switching gears for a bit and turning our attention to the fall, considering whether we may experience a second wave or a surge during the fall months. While it may be a matter of semantics, it probably depends largely on geography, since the pattern and prevalence of COVID infection right now in New York State and much of the Northeast is very different from what states elsewhere in the country are experiencing. And there's also the possibility, which would be terrific, that the success we've achieved here in New York can be sustained as we move into the fall and winter, but that's certainly not something we can count on. So when we think about what the fall may have in store, we can look at historical patterns of infection, and one of the groups that studies this is called CIDRAP, or the Center for Infectious Disease Research and Policy at the University of Minnesota. And they have a viewpoint working group that has been very active in looking at historical patterns of infection and predicting what may be in store for us with COVID in the months ahead. And they have a very robust website that contains links to position papers, white papers, and also podcasts that they publish on a regular basis. So although much uncertainty remains about the future of COVID and no one's crystal ball is totally clear, most models suggest that the current outbreak is likely to last 18 to 24 months, and that the threshold for achieving herd immunity in the community is about a 60 to 70% infection rate. It turns out that the best comparative model for COVID is pandemic influenza, and we know that there have been 8 global flu pandemics since 1700, 4 of which have occurred since 1900. The major pandemic of 1918, the 1957 pandemic, 1968, and the H1N1 pandemic in 2009 to 2010. The epidemiology of other severe coronaviruses, such as SARS and MERS, is not really useful for comparison to COVID-19. The similarities between COVID-19 and pandemic influenza are that these are novel pathogens. So there's widespread susceptibility in the population. There's respiratory transmission. There's asymptomatic transmission. And all of these create a scenario where the virus is capable of achieving rapid spread and causing millions of infections. There are also some differences between COVID-19 and pandemic influenza, one of which is the longer incubation period of COVID-19, which averages 5 days with a range of 2 to 14 days, compared with influenza, which averages 2 days with a range of 1 to 4 days. There also seems to be a larger asymptomatic fraction of COVID-19 infection within the population, and the time frame of pre-symptomatic or asymptomatic shedding appears to be longer, with prolonged viral shedding in many individuals, though it's unclear how much of that prolonged viral shedding contains active viral particles that are capable of causing infection upon exposure. And there's also a good deal of uncertainty and variability regarding the reproductive number, or R0, of COVID. The characteristics of past influenza pandemics are such that 7 of them had an early peak with substantial resurgence after 6 months, which is what's causing concern about what we may face in the fall. Some also showed smaller waves of infection over a 24-month period, and only the H1N1 pandemic was substantially altered by a national vaccination campaign. Since 1900, 3 of the pandemic strains became more human-adapted and as a result became endemic and became the prevalent strain in subsequent seasons. Most recently, this occurred with H1N1, which is why H1N1 is, and has been now for 11 years or so, a component of influenza vaccines each year. The characteristics of the COVID-19 pandemic are a bit different in that we still have limited data regarding surveillance and actual numbers of cases, which is what contributes to the uncertainty regarding the R0. Now, most estimates are that the number of actual cases is substantially larger, perhaps 10 times larger, than the number of cases that have been confirmed with testing. It's also uncertain if and when herd immunity will be achieved, and the duration of immunity following infection is still largely unknown, simply because the longevity of our experience with the virus is so limited. The timing of vaccine availability is unknown. There's certainly a lot of speculation about a time frame that encompasses the end of this year or early next year, and it's also uncertain how widely accepted a new vaccine will be in the general population. And of course, the biggest confounding factor with respect to COVID-19 is the lack of a uniform response within the United States. We'll have an opportunity in future sessions to explore some of these concepts in a bit more detail. It's important to point out that the incidence of influenza during the spring, the tail end of the last influenza season, once we began to modify our behavior by using masks and social distancing, was also lower than expected. As always, we welcome your suggestions and feedback for these sessions. Thank you for your attention, and back to you, Liz.
The rest of the slides here are resources available for your use, some resources on supporting healthcare provider well-being, the peer-to-peer MISNI program for support for wellness in healthcare providers, the text option for healthcare provider and frontline worker wellness and emotional support, the New York State Mental Health Helpline, other resources available here, telehealth guidance, and some of the printable materials are here and available for ordering or printing. A reminder that New Yorkers still have an open option for New York State of Health through August 15th. And again, I think one thing that we would all like to do again is give an enormous thank you to all of you in public health, healthcare providers, as all of these numbers maintaining these low rates is from the work of each and every one of us involved in this call, listening and joining this call. Before we go to question and answer, we wanted to show a fun an ad that's available nationally that we here in New York State have put out. So we'll show this brief 30-second or so ad, and then we'll move on to the question and answer session. that fun ad that I got a kick out of, so I thought all of you would as well, and apparently that is showing nationally. Okay, now we'll go on to the question and answer session.
Thank you, Liz. So there were still a lot of questions about testing and so forth, and a lot of concern that the commercial labs are backlogged. And there's a question if the Department of Health has any recommendations for prioritizing tests of higher risk individuals.
Yeah, so certainly when there are high risk exposures, specific test plans can be made with your local health department peers and us at the New York State Department of Health. So in sensitive settings, high-risk settings, there may be specific approaches to both making testing happen for larger groups of exposed individuals more rapidly and readily, as well as for ensuring that those specimens are prioritized. So in those situations, it's essential to discuss with the local health department. For individuals in the clinical setting, in the outpatient clinical setting, again, if there's not an urgent medical need, then it would be best to try to call and seek out local New York State labs versus the larger commercial national entities that are overburdened. And we continue to try to work with these partners to expand access and availability. Additionally, in the high-risk settings, such as the hospital setting, certainly many healthcare facilities have started to set up processes to ensure that those individuals who need it, who are hospitalized and quite ill, can be prioritized within that medical setting.
And then a similar question, but a little bit different, because of the backlog, and there is a concern that these antibody tests are kind of like clogging the pipeline for PCR tests that are, and I just wonder if you can talk to that, because I think that should not be a concern, but I'm curious.
Yeah, that's a good question that came into our question email box here. And really, we have a lot of challenges with, standing up in a matter of months now, millions of tests here. But I don't think that the antibody testing is necessarily slowing down the molecular testing. There are different supply chains for the reagents, different kits. Different, obviously, the molecular is typically an NP swab, if not a nasal swab, if not saliva, which is different than the serology, which is a blood test. So different specimen collection kits and routes, different types of labs that perform these tests. And so I don't think that the antibody testing is necessarily slowing down the molecular test, but certainly, again, the emphasis is that we need to all be aware of what's going on in our communities with turnaround time. We need to engage with our local health departments to have a better understanding of that if we're not sure, and to also engage with them with prioritization testing. And we need to, fill out any lab requisition very perfectly, more than we would normally pay attention to, with first name, last name, date of birth, address, phone number, because we really, in this case, not only does your practice need to call back the individual with the positive, but our contact tracers need to get in touch. And so that really helps speed up that process.
Then there were a couple questions about kind of, again, like best practice in practices about PPE when drawing blood on patients with or without suspected COVID. Is it enough just to do a face shield or surgical mask, or do we need N95s and wear gowns? Any recommendations there?
Yeah, so this is not an aerosol generating procedure where the N95 is absolutely critical, and this is not a suspect case per se. So in this situation, we are talking about drawing blood on patients, and we would want to follow the guidance, the CDC guidance right now on the universal face mask or surgical mask approach to all patient care to protect even from those who may not be displaying symptoms of COVID. And so that would be appropriate here as well. And so I would say that the face mask is important, not necessarily the N95 when it's not a suspect COVID case and not an aerosol generating procedure. Importantly, I will also mention that the CDC, about mid to late July, did update their guidance regarding face shields or eye protection and encouraged the use of face shields or eye protection universally in healthcare settings, in settings with moderate to high community transmission and areas of low transmission. They comment that is an optional approach. And so that would be the consideration there as far as eye protection.
Thank you, Liz. And I can just, in my practice, we switched and we are wearing now face shields, like for every patient encounter and every contact, so forth, plus masks, of course. Yeah. And so that is certainly, although I don't think that we are like high community spread here in Albany, but we are doing it just to protect us and our patients as well. Another question about where do the results get reported to state, county, DOH, and there is some concern, like if you go to your local pharmacy, will DOH or the local counties will they get these test results and so forth? So maybe you can comment on that.
Yeah, absolutely. So we have a very robust in New York State system here at the New York State Department of Health for electronic lab reporting. So all COVID test results, in fact, even negative and positive, are reported automatically through an electronic lab reporting system to the New York State Department of Health. And that system works very well. So all of those tests, such as a molecular test done at a pharmacy or an urgent care, those do come, or a federally qualified health center, et cetera, those do come to us and reach our public health system at the local health departments and our contact tracing initiative folks. However, it is important to note what was previously mentioned, that the rapid antigen point of care tests are becoming increasingly available. And we do have concern that those tests that are performed at point of care, say in a private practice, or some have discussed in a potentially moving forward in a university type setting, those are not sort of already hooked in with our electronic lab reporting system. So it's really critical if those are used, particularly with the positive tests, of course, but all test results should be reported to public health, to the local health department and the New York State Department of Health. It can go directly here, and we would share it with the local health department or vice versa. There is a process for that, and if anyone would like to inquire, please reach out if you're doing that point of care antigen testing to us, and we can provide that process and that information. You can reach out to our standard BML, which is
COVID provider info@health.ny.gov.
Thank you, Marcus. I can never remember it. And let me ask Marcus a couple questions here. So we do have a question that came in. Is there any vague timeline as to when other larger gatherings or settings such as gyms might come back on in the reopening phase? And what does that discussion look like?
Yeah, it's a good question. I think we are still very worried about levels of community spread in COVID, and I think that we are of course observing what's going on in New York State right now, and I think it all depends on the numbers and certain metrics that were put forth for opening certain regions. I was very surprised on the radio. They talked about like larger concerts in Great Britain right now, but I think people are starting to adapt to the reality of COVID, that COVID is not going to go away, so you have to start learning adaptation. And they actually, like in these larger concerts, didn't put all the people together, but made sure that smaller groups of people are social distances from each other and therefore can attend a concert. And so I don't have a crystal ball. I'm not sure about the vague timeline. I know that these measures are evaluated on a weekly basis, on a rolling average, and that there is always a discussion about could we allow it or could we not allow it. And so I'm a little bit hesitant to kind of like make a prediction here, but we will see how the fall goes, and then I think based on our experience there and also on the community spread, that we will revisit that decision going forward. And then the last question I have, again, like a testing questions is, are there any self-administer or rapid test that we can hand to our patients, or parents could self-administer, if they are not feeling that they should come to the office? And I know that in one of the earlier webinars you presented a slide that there are like home tests available now, and I just want to know if you can comment on those again.
Yes, so there are certainly home specimen collection sets that are available. For instance, LabCorp offers them. If you go to our website and look for where to find a test, you'll also see that pop up no matter what zip code you enter there, what city you enter there, as it's an option statewide. It's not a home test per se, as the test obviously is not done in the home, rather at LabCorp or the commercial entity, but the specimen collection is done at home with a nasal swab. So that is an absolute option for folks. It gets mailed to the home with very clear instructions and then mailed back, and then the result thereafter. We've also heard about some of the universities using a similar approach. And we've heard feedback that worked well and was simple instructions to follow. We would also say that the rapid point of care tests are becoming more available, as mentioned. It's important to note that the sensitivity of these tests, when compared to the gold standard of the molecular or PCR test, is significantly lower, somewhere around the 80% or 85% sensitive range compared to PCR. We don't have another gold standard other than PCR at this point, so that at this point has been the typical comparison. And so that, of course, is of concern, as we have similar concerns with an influenza rapid point-of-care antigen test, that we might miss some true cases. However, what we don't know is in the setting of not a clinical concern, but rather a public health concern, if that test is maybe better, more useful than that 80% number would suggest. So, for instance, one recent study looked at replicative virus in the lab, so suggesting infective virus. And although the antigen test missed, quote unquote, some positives that the molecular test found, it was typically many days later when we no longer would find infectious or live virus. So it is theorized by some experts that maybe the molecular gold standard is almost too sensitive if you're looking for specifically infectivity. Of course, in the clinical setting of a hospitalized patient, you want to know what's causing their disease. You want maximal sensitivity to establish if that is the disease at hand. However, in a situation with, say, an individual who is symptomatic, mildly symptomatic, it is not a significant concern for their health, but rather it wants to be established. In that situation, we want to establish as quickly as possible whether they have the disease for public health community control. Some experts have suggested maybe the rapid antigen tests are more useful given the very easy availability and rapid turnaround time, and that maybe it's better in its sensitivity for picking up those who are infective with higher viral loads. So that is a suggestion, and I think they are being used more and more. However, the the Association for Public Health Laboratories, the APHL, does not, because of that, some of these issues with sensitivity and specificity, recommend use for asymptomatic individuals. So in asymptomatic individuals, you may see some false positives, even though the false positive rate is felt to be low. But when there's a very low prevalence and an asymptomatic individual, we may still see that. And there's that concern that it's just not an appropriate use of the test in those who are asymptomatic, and we're screening them for purposes of their employment setting or their other kinds of settings. So they do not recommend it because of those caveats, but some may choose to use it given the availability in certain settings, and particularly when symptomatic, it may be more useful given the rapid turnaround time.
This concludes our webinar for today. Again, I want to thank all of you for calling in or getting on the website. I want to thank especially for you who are providing all the care for our patients on the front line. fine. Stay safe. Hopefully you will get some vacation. At the time being, it is destined to be a busy fall for us. So thank you again for all you're doing, and have a good day.
Thank you.